Okay, good morning, everyone. So now it's our time, so let's get started. So welcome to the session on the universal health coverage, especially on the collaboration on the multiple health stakeholders. And I think in many countries in the world nowadays working very hard for toward the universal achievement of the universal health coverage, including the improvement of service delivery and the strengthening of financial protection. But especially for the financial protection, there's many players, many stakeholders. It's not only the Ministry of Health, but also the national health insurance agencies and the Ministry of Finance also. And in some countries, academia provide the scientific evidence to navigate your policy on health financing. And also the other development partners, including JICA. So there's it's very important of the needs for the dialogue among the different stakeholders, and while each of the stakeholders have a different perspective, even for the our goal is the same. So in this session, we invite a resource speaker from the Senegal and Kenya and Egypt, but representing not only the health insurance authority, but also the Ministry of Health service provider or the health financing policymaker, as well as Minister of Finance. Especially for the health people, they are the one who you need to negotiate for the more allocation of the budget. And also the academia, who especially the JICA is supporting Senegal for the health insurance development, and we are also conducting the impact analysis together with a collaboration of the one Japanese university as well as the Senegalese university. So we here in this session, we'd like to share the different perspective, different ideas for the financial protection mechanism. So first, I'd like to invite Ms. Yoshii. She's the director of the health and in charge of the Senegal. And JICA has been providing for those three countries not only a technical cooperation for the financial protection, but also the loan scheme, especially for the developing the health policy on health financing. So she provides you some overview how JICA has been making a cooperation on the financial protection of those countries. So Ms. Yoshii, over to you.
So good morning, everybody. My name is Yumiko Yoshii from JICA. So very happy to be here. So first of all, I'm pleased to briefly share the overview of JICA's cooperation for accelerating successful health financing reform toward UHC. So JICA has been working with countries on achieving UHC by developing our cooperation strategy called JICA Global Agenda for Health that aims to contribute to the achievement of UHC at the country level. It also tries to accelerate the progress toward achieving the target goal set in the SDGs. So under this cooperation strategy, we've been implementing several projects in different modalities. So one of these is development policy loan. It's a kind of a non-earmarked general budget financing, and it is a modality to disperse the fund when a set of policy actions that are mutually agreed between the recipient government and JICA is completed. Then thereafter, the dispersed fund goes to the general budget account in recipient countries. By doing so, it aims to create financial incentive for implementing agencies to accomplish the policy actions, and it encourages implementing agencies like the Ministry of Health to have a policy dialogues with Finance Ministry for budget request and allocation. Well, so together with the development policy loan, we've been providing capacity building opportunities at the national and subnational levels through the implementation of technical cooperation projects to achieve the policy action set in the development policy lending. We've been taking such kind of a combined approach, development policy loan plus technical cooperation, to accelerate the country's progress toward attainment of UHC in Senegal, Kenya, and Egypt so far. For example, in Senegal, well, together with Senegalese government and authority, we are focusing on increasing the coverage of community-based health insurance to improve the physical and financial accessibility to quality health services, especially among the vulnerable population group. Then, when it comes to Kenya, where health service delivery is devolved, we've been working on optimizing financial management and accountability in the health sector by disseminating medium-term expenditure framework management tool, which is developed by the JICA's Technical Cooperation Project. Then, last but not least, in Egypt, in close collaboration with the Universal Health Insurance Authority, we've been implementing projects to strengthen financial protection through universal health insurance system, and also improve the quality health service delivery by enhancing accreditation system and hospital quality improvement. Well, so in summary, by the combination of development policy loan and technical cooperation, we aim to increase the physical space for health and also build the capacity for managing the health system in an effective manner. So that combined approach generated the opportunity for policy dialogues between the Health and Finance Ministry for working together toward UHC. So now, I'm excited to hear from our distinguished speakers coming from different ministries and agencies to delve into more detailed country experiences in multi-stakeholder collaboration for health financing reform toward UHC. So let me pause here and thank you.
Thank you very much, Yoshi-san. So now I'd like to present the first Senegal delegates. And from Senegal, we have two speakers. One is from the Health Insurance Authority, the health financing protection provider. And the second speaker is from the Ministry of Finance, who is not only taking care about the health money for the health, but also the competing interest among the country. So I think we can hear the different the perspective from the different point of view. So first, I'd like to welcome Mr. Faye, the technical advisor for the universal health coverage of the Ministry of Family Solidarity, Senegal, which is in charge of the Health Insurance Authority. So Sete Faye, over to you. By the way, we have many speakers today, so I'd like to remind you to limit your presentation in 8 minutes. And Miss Kamiya, she can support you to by the prompting a time, or sometimes she may the bumping the bottle to make announce you 3 minutes or 1 minute, or time's up. So I know that you have many things to say. Wow. Yeah, try your best.
Good morning, ladies and gentlemen. My name is Jabil Faya. I'm the technical advisor for social protection and universal health coverage in the Ministry of Family and Solidarity. I would like to make a presentation on the demand side of UHC. I'm also the technical advisor for UHC. So the theme today is to talk about the reform of health system for fair and sustainable universal health coverage, and in Africa with the role of collaborative governments in complex health system in the case of Senegal. My presentation will have 5 points. So first, some steps on the restructuring of health insurance implementation system in Senegal. Second, current issues and challenges of the demand side of UHS. Third, development of the support loan that has been put in place in Senegal through JICA, so phase 1 and 2, and the objectives and the results that we had. Then fourth, the digitalization of health insurance in Senegal, and some future prospects. So first, the steps of the restructurings. First, please understand that Senegal, we had a new plan, and we netted to create the UHC agency, which is called CMU, in 2015. And then a few years later, we understood that it was better to separate supply and demand. And in 2015, we were really in the Ministry of Health, but in 2019, we decided to separate both. And we had on the one side, so the CMU agency, the UHC agency, if you want, and the ministry. Then after a few years, we had to make an assessment, and there were some recommendations were done by the academia. And it was asked that there was a shift from the CMU agency to the Senegalese agency for UHC, which is called CSU, so that the agency became was the insurer, but now the agency is going to pay for the services. Second, and then is the idea of portability of health insurance. We do not have it in Senegal right now because we are in a region or departments, and when we are in region, it is important to look at this. So we need to go from, if you go from one region to another, to have the same portability. Also, we had the gradual introduction of compulsory health insurance through systematic subtractions. And this is something that we called smart requirement. So the state tries to put the link with health insurance. So it has to be connected, the health insurance, the drugstores, and the healthcare provision. Second issues is the definition of the list of medicines that are eligible for UHC. We're working on that. Second, the registration of beneficiaries. This is also very important. So we put in place a unique number and the provision of insurance cards. And we also need to have tools and to put in place, for example, negotiations with healthcare provider on reduced rates in health insurance, so especially for the people who are most vulnerable. Another issue was the stabilization of management of subcontraction model. So now we are going to have the agency will be the insurer, but some of its missions will be subcontracted into mutual insurance companies. And this is something that is in the 2014 decree. We set up also a structure for the control and the monitoring. And you had, of course, the salary people, you had the civil service people, but also those who did not have and are most vulnerable, so that they can be covered also by health insurance. Then third, I would like to talk about DPL1 and DPL2, so the loan. And it's important to have cooperation between several ministries in order to have a real universal health coverage. So 1 and 2, we had 2 phases, but it's the same thing. The idea was to strengthen coordination, governance, and financing, to strengthen the health coverage system for the most vulnerable groups, and to strengthen the system of basic health and social actions. So what are the results? So very rapidly, there has been a strengthening of the health system and the quality of healthcare. And we've been increasing the amount of subsidy to mutual health insurance companies. And we had also health center with emergency obstetric and newborn care blocks that were equipped. And the Ministry of Health also gave a lot of help in those EMONCs. And within the collaboration, it is important to talk about governments also. What we should remind us is that we have the supply and demand, but we have other stakeholders like the Ministry of Finance and so on. So in DPL1 and DPL2, we made a lot of efforts, especially in DPL2, so phase 2. We managed to negotiate with the Ministry of Finance, and there was a lot of efforts made so that now we have better funding within DPL2, because DPL is a support loan for budget. So it's within the state budget, and then you have to negotiate with each ministry in order to get the budget. So with DPL2, we managed to negotiate 5 billion francs and 1 billion is actually directly given to the Ministry of Health and Social Action. So we managed to find that 75% of the loan will go for demand and 25% for supply. So that was within DPL2. That was a very good result. Finally, the DPL managed to have better dialogue between the various stakeholders. We managed to work correctly together. Now, a few prospects. So DPL2, we have a budget support, and we tried to assess this in order to prepare for DPL3. So we were talking about the Ministry of Finance. Why not direct it, like for the World Bank funding, to make a contact with a project that would be clearly earmarked? So according to well, for example, World Bank loans, you sometimes have that are earmarked. So we thought that it would be good if we can see with the performance. This is how we can maybe use it better. As I told you, we had already 5 billion, and this, of course, we cannot get the whole budget that is being given, but at least we can limit the idea and know exactly how much money we can use. Let's go on digitalization of the health insurance. We tried to use the functionality of the SITFAC and the GESTFAM, which are actually management and invoice systems. And so it's better to, it will be easier to manage the subscribers, and especially that payment is due on due date and so on. And also, we've started to ensure change of management to successfully achieve the digital transformation of UHS. So as I told you, so the registration of beneficiaries, I know I have only 30 seconds left, so I will go very rapidly. And now we have to also to modelize the framework and set up also scaling up GESTAM and SITSCAM. Basically, this is what I want to do. I'm sorry I didn't have much time to go through it, but these are all the issues and what DPL1 and DPL2 added to it, and the prospects in order to have maybe projects that would be earmarked. I have finished, and thank you very much for your attention.
Thank you very much, Certified. So the one of the key messages he delivered is the JICA or many other development partners usually use the development policy loan to support the health financing, but such a support is general budget support. The money, loan money, not the directly go to the health ministry or health insurance authority, but it goes to the general budget account under the Minister of Finance, and it's the Minister of Finance who decide how to allocate. And from the health insurance authority side, he prefers money directly goes to the health insurance authority. But for the Minister of Finance, maybe the other different viewpoint he may have. So now, second from a speaker from the Senegal, I'd like to invite Sete Jo, Conseiller Technique, Technical Advisor for the budget framework and the public finances of the Ministry of Finance and Budget of Senegal.
Good morning, ladies and gentlemen. My name is Sheikh Tidiane Do. I'm Technical Advisor at the Ministry of Finance and Budget, and I'm in charge of doing the monitoring of budget loans and budget for all ministries. I'm also in charge of following the loans that we have from IMF. I would like to make a short presentation of UHS in the budget policy of Senegal. So first, let me remind you our missions of the Ministry of Finance and Budget. So our ministry must centralize the preparation of draft finance laws that are going to be adopted by the Council of Ministers. And to this end, it sets the budget of each ministry and institutions. And it monitors also the distribution or the allocation of those budgets by the ministries. So it is not just allocated without any idea. So this allocation should be in accordance with the government guidelines and in compliance with the budgetary rules. So this is our monitoring. So we see the guidelines and we respect them. We do that in accordance, but the priorities have been decided by the government. And then also, we must consolidate the budget documents and to prepare the arbitration cases. It proposes also the draft finance bill that will be looked in the Council of Ministers, and in the end, it will submit the finance bill to the National Assembly, to the Parliament. Senegal, as far as health is concerned, and our priority when we have to make some decisions, we have to remember that health is an inalienable rights for each individual. So UH coverage is a requirement, a social and economic requirement, and something that is absolutely necessary if we want to have justice and social equity within the framework of the government's new development strategy. The name is Senegal 2050. And you have in this chart the various social benchmarks. So the main idea is to have Senegal as a fair country in 2050. And the government tries to do that by looking at the figures you have in the chart. So for 2023, the population was 18 million of inhabitants, but the aim, or let's say the estimates by 2050 would be that we would be 35 million of inhabitants in 2050. The GDP per capita in dollar in 2023 was 1,660, but the aim is to be around $4,500 per inhabitant, per capita. The HDI, right now, we are at the 169th rank out of 192, and we would like to be below the 100th rank by 2050. The poverty rate in 2023 was something like 37%, but our aim is to reduce it by 10% by 2050. The mortality per 100,000 births was 216 in 2023, and we aim at 70 by 2050. And the share of Senegalese people that are supported by UHC is 53% right now, but that was a survey that was done between 2019 and 2023, and the aim is to have 100% coverage by 2050. But in order to do that, we need to include all the informal sector. So this is a top priority, and we try to measure it through the budget allocations, because this is how you can see how priorities are really being made. And if you look at the changes of those three lines, so on the bottom one is the budget for UHC. In the middle, orange, you have the budget of the Ministry of Health and Social Action. And the blue line is the budget for the whole health and social security. So really, you can see that there are some fields in social sector that is not within the the Ministry of Health, but in other ministries. For example, for school, for education. So school health is done with the Ministry of Education. You also have some with the army, and it covers the military people, but not also some inhabitants because they are helped by the army. We also have other sectors that are being dealt by other ministries. So this budget does not include the civil servants UHC because they have several different level, and this is done actually by the Ministry of Finance directly, so for civil servants. So now, with partners or donors like Japan, was helped us in order to have more resources for UHC since 2022. And as you can see on this graph, starting in 2022 with DPL2, the 3 lines started to go up. So you can see an increase of the budget for health and social action. It can be on all levels, really, be it for the Ministry of Health or for the other ministries and for UHC. The efforts that were done by the state have brought a lot of results, positive results, because it was possible to increase a few things. For example, an increase of the budget over 3 years. And the UHC budget allocations almost doubled. And what is called CSU in French is UHC, of course. And this was done through DPL2 because through DPL2, there had been a commitment to increase continuously the budget. That was really a commitment, and this is why it was very important to work with the donors in order that the sectors of health and social action be a priority or a bigger priority in the government agenda. We have also the opening of UHC offices in all health centers and hospitals in Senegal, and also the gradual use of softwares for healthcare services. We recruited also 150 staff for UHC offices. We developed also guidelines for the UHC offices. We improved almost the services for the emergency obstetric and newborn care, what's called SONU in French, and also the creation of 46 mutual insurance company in each department, which are each regions. But we still have some challenges because there is a lack of a law saying that the health insurance would be compulsory except for the people who are salaried in a company. This is compulsory, but it's not the case for the informal sector. With UHC, we are making efforts to include also the informal sector, but it is not compulsory right now. It's just incitation to have it. We also have insufficient financial resources because we are a developing countries and we have priorities in many fields. And this is why when we have to allocate budget, it's difficult to decide which should be a priority. So when we have to make decisions, of course, health has always been a priority in the final governmental decisions. Also, we have a poor consistency of the information systems of the different health risk coverage schemes. And now we have a single national register, which helps us to really reach the very poor, the most vulnerable, who right now have more coverage thanks to UHC. What are the prospects? It's very promising. Thanks to our partners and donors, they should help us to give more priority to social issues and health, so that by 2050, the aims through that are actually explained in Senegal 2050 be actually implemented. So thank you very much for your support and for your attention.
Okay, thank you very much, Setejo. So as a Minister of Finance, as the output of the development policy lending from JICA, he almost doubled the budget for the health insurance agency, and 50% increase for the Minister of Health. And of course, he still needs for the financial resources, especially to cover the poor and vulnerable people. So let's continue to have a dialogue how we can cooperate. So the next country that we'd like to invite the delegates from the Kenya, Dr. Elizabeth Wangia. She's a project manager for the World Bank project, but she was the former head of the Directorate of the Health Financing, Minister of Health in Kenya. So I'd like she to share the perspective and her action for the health financing reform in Kenya. Dr. Wangia.
So thank you very much, JICA team, for giving me this honor. First of all, I would just like to give a brief on where we are as Kenya. Kenya has been undergoing quite significant reforms in terms of the health sector over the last, I would say 10 years, but in the last 2 years, we had a new government, and the new government came with key priorities, of which health is one of the main priorities. So I'll just start by giving up the government's agenda, the current government's agenda, and knowing that the topic of discussion is around multi-sectoral collaboration. I'll touch very lightly on the government agenda, then go into how multi-sectoral collaboration has assisted. So the current government's agenda has 5 key priority areas around agricultural transformation, micro, small and medium enterprise economy, housing and settlement, digital superhighway, and the healthcare, what we call afya nyumbani, meaning healthcare in the communities. So within the healthcare, we have also 5 key priorities, looking at strengthening human resource for health, effective supply chain for health products and technology, health financing, integrated health information system, and primary healthcare as one of the key priority areas. We are looking at moving, having a paradigm shift from currently, the health sector has been largely supporting curative care, but then now we want to shift towards preventive and promotive care, which is more sustainable. We want to move away also from vertical financing to a more integrated way of financing the healthcare. And looking at primary healthcare, it has been quite fragmented. So we want to more or less align the primary healthcare, and all this will enable the financing structure to be more sustainable. And within the health financing, the reforms touch around moving away from just voluntary insurance or voluntary payments to more or less compulsory, and also movement from out-of-pocket payment to prepayments. And we also want to move away from or reduce external funding and emphasize on domestic financing. Looking at the trends of the budgets of within health, we can clearly see that over the last 10 years or so, the budget has been increasing, and Kenya has a devolved system of government with 47 subnational units called counties, and we can see at both national and county level, the budgets have been gradually increasing. what we really need to analyze is whether this is a true increase, because over the last 10 years, there's also been population growth and also inflation. So yes, in terms of absolute numbers, we may have gone up, but if you net off more or less inflation, population growth, we may realize that that the budgets are not as high as it may be. So in an attempt to emphasize, to move from curative care to preventive care, we are really, the government is investing mainly in primary health care, where the level, what we call level 1, which is the community level, and level 2 and 3, which are the primary level facilities, are publicly financed. Then we have social health insurance to cater for the hospitals. And also we have what you call the Emergency Chronic and Critical Illness Fund to cater for emergencies and chronic illnesses that are likely to cause catastrophic health expenditures. So with that, we went into reforming the health financing, where we passed what you call the Social Health Insurance Act that established the Social Health Authority that has these 3 funds that are in alignment to our financing pyramid that I presented there. So we have the Primary Healthcare Fund, whose purpose will be to purchase services at primary healthcare level. And this is totally government supported, which is tax funded. Then we have the Social Health Insurance Fund, which is contributory. And by contributory, it means both the formal and informal sector, and also the government contributes on behalf of the people who are unable to contribute because they are poor, so as government subsidies. Then we have the Emergency Chronic and Critical Illness Fund, which is also government supported, which caters for emergencies and also chronic illnesses, chronic and critical illnesses. So just quickly going to the role of multi-sectoral dialogue in health financing reforms. Just looking at what really made all this a success. So one, given that we passed key legislations, we really needed the support of the Office of the Attorney General, where we got quite a number of legal, what we call state councils, who enabled us do 4 critical acts. And we, the president passed 4 critical bills, what we call the UHC bills. Then we have the Department of Social Protection, which working together with the national government and county government will identify those who are in need of subsidies, insurance subsidies. Then we have the bilateral implementing partners who came in when it came to development of the bills, regulations, and capacity building. Civil society, they always keep us in check. Those who know Kenya know that we have a very strong civil society. The private sector came in handy, especially when it came to digitization. Currently, we have an arrangement with one of our key private sector players to digitize the entire health system. The Council of Governors, as I mentioned, the health sector is devolved. So we cannot do anything without the county. So the Council of Governors came in handy when it came to development of the bills and, of course, implementation of the roadmap. The members of parliament, we know that these are people who we cannot do without, especially when you're thinking about passing laws and all that. So they came in handy when it came to passing laws. The office of the president, this is an agenda that is very dear to the president, and therefore the representatives from his office and the president himself has taken keen interest on that. Amongst other stakeholders have been the health regulators and associations who supported us when it came to development of the benefit package, because these are the technical experts, and not forgetting the community health promoters and religious organizations. Moving away from the health sector, we have other sectors like the Ministry of ICT that is supporting us in the digitization, Ministry of Energy. In Kenya, not all facilities, especially at primary care level, have power. So you may have good plans, but they don't have the electricity to even support the equipment for digitization and reporting. Then we have the Ministry of Finance, Ministry of Cooperatives, and the Ministry of Interior, where the chiefs are, because these chiefs also deal with the people on the ground. So we have been using them as agents of change as we work in all this. So maybe just one slide on the challenges of implementation. One main challenge is around change management. Anytime there's a change, there's of course change management, public mistrust, so we have to work around that. Staff apathy, we changed from what we call the National Health Insurance Fund to the Social Health Authority, and this affected the staff who are in the National Health Insurance Fund. So that, of course, with inadequate digital infrastructure have come in as a challenge, of which we are working on gradually. So I'll stop there and welcome any questions. There'll be other opportunities during the plenary. Thank you.
Thank you very much, Dr. Wangia. I think her presentation illustrates how many the other stakeholders are related to such a big reform on the health financing, right? We are very much impressed. And the other last country, I'd like to invite the other Professor Ihab Awaj. And he is currently the vice chairman of the Universal Health Insurance Authority, Health Insurance Agency. But right before that, he was taking a position of the former vice minister of the Ministry of Finance. So I think we can hear the different point of view, two double viewpoints from the Health Insurance Authority head and also the other Minister of Finance. Okay, the other Dr. Ihab, over to you.
Bismillah ar-Rahman ar-Rahim. So good morning, everyone. I'm very pleased and actually to be here in Japan, land of both history and modernization, and very proud as well to share the floor with these distinguished guests. But this shouldn't be counted in my 8 minutes time, by the way. Actually, so my time should start now. What I'm going to tell you quickly today is about our experience with the universal health coverage, and actually two key slides I will focus on. One slide related to the ecosystem we have for the universal health coverage, and the last one is the lesson learned so far since the issuance of the law in 2018 and start the rollout, while we have a gradual rollout system for the implementation, which is started 2019. So these are the key 3 points, and actually these are the abbreviations I'm going to list. So simply about the country context, the per capita capital to some extent is a little bit above 3,500, and actually the current health expenditure, governmental health expenditure, representing a little bit over 4.7%. It represents 30% of the current health expenditure. The national health accounts and actually results showed that 60% are out of pockets, while the other 10% is related to other parties within the government. Right now, we are running the current health accounts with the WHO. We are expecting that the governorates that fully applied the system, the out of pocket will be reduced to around 40%. As I said, and actually since the issuance of the law in January 2018, the health sector has witnessed and actually lots of reforms. This is the key slide that shows and actually the ecosystem we have. So we can see 8 key players in the system. 2 of them are the ministries, Ministry of Health and Population, which is basically the super regulator and the purchaser of the preventive healthcare services, and the other ministry is Ministry of Finance, which is responsible basically about the funding and upgrading the health facilities before handing it to the universal health coverage authorities. We have 3 supporting authorities: the Egyptian Health Council, which is basically the regulator for health practices and clinical protocols, and the Egyptian Drug Authority, and actually which is the regulator for health technology and all the drugs, the UPA, Unified Procurement Agency, which is the bulk buyer for the drugs of the system. And then we have the 3 GRI ones, which is actually the 3 authorities related to the universal or managing the and offering the universal health coverage. The first one is actually authority, the Universal Health Insurance Authority, which is basically responsible about financing and purchasing and managing as well the whole system. The second one is GAHAR, the authority responsible about accreditation and controlling quality. The third one is the Egyptian Health Care Authority, which is the public provider or the governmental arm that is responsible about providing healthcare services, beside, of course, other private sector. So this is the ecosystem, and these are the key relations between and actually the different players in the system, specifically the 3 green ones, which are issued according to the law of universal health coverage in 2018, but of course the post ministries are far before that, and then followed by the 3 supporting agencies in 2019 and 2020. Talking about more about the Universal Health Insurance Authority. So as I said, its role is basically about managing and financing. So we are basically responsible about revenue collection and pooling, purchasing, identifying the benefit package, and currently we have over 3,400 medical services, healthcare services, and over 4,600 drugs, different drugs, and actually allowed for our beneficiaries. Of course, the reimbursement, the costing, and the pricing as well, and actually. We are responsible about contracting with the private and even public service providers, and I'm going to show you the statistics later on, and the claim management, and as well the IT ecosystem. If we focused more on the sources we have, and actually because the Universal Health Insurance Authority and financing is a little bit away from the budget financing to some extent. So we have, by completing the system, we will have 3 equal sources of money. But currently, I will tell you about the current statistics after about 6 years of the implementation. The first source is the air market taxes and corporate social solidarity contributions, certain fees on cigarettes, certain fees on tool stations. And then the third is the premiums and co-payments paid by the beneficiaries. The third one is the subsidies for poor and vulnerables received from the Ministry of Finance. But an extra one we tended to have right now, which is the return on the surplus we tended to accumulate over the period. So currently, we have our financial statements, so that shows that we have of our accumulated and actually surplus, which about $3 billion, and actually its return of investment is about 25% of it. Air market taxes and actually representing on average 50 or 60% and actually of the annual income. Premiums and payments represent about the 10%, because we just entered so far and actually the system in 4 governorates. The 5th governorate will start formally in 10 days. The Suez Canal 1, the one in blue there, because the first phase had 6 governorates, and actually 4 of them already, the 5th will be in 10 days, and the last one, Aswan from the first phase. Currently, we have a little bit more over 3.7 million beneficiaries, and 20% of them are vulnerables. The average enrollment percentage and actually is 82%, and actually we are contracting with a little bit over 370 service providers. 24% of them are from private sector, although with respect to value, to some extent, the claims are only 5% for the private sector, while 95% for the governmental arm. And actually, these are the challenges we are facing, and we will try to sort out by increasing, as I mentioned, and actually the private sector, because the plan is, and the actuarial study is depending on having a contribution of the private sector around 40 to 60% of the healthcare service provider. By currently, as I said, it's about 24% only. Enlarge, of course, the informal sector in enrollment. Currently, we have, and actually about 20% of the informal sector for these 5 governorates, and actually to another 20% of the poor, and the other is the formal sector. Accelerate the ecosystem and review all the time and modernize the benefit package and the pricing, especially due such high inflation periods. Yeah. Finally, and the recommendation for universal health coverage in general, it needs a strong and actually political commitment, because whenever you have a system that impose certain commitments over and actually the population, it tended to have resistance to some extent. Strong, again, private sector engagement, because at the end of the day, governments will not be able to do alone and to offer all the healthcare services needed by the population. Very strong attention to financial sustainability and resilience, and we might elaborate more about that. And actually, great emphasis on benefit package and pricing methodology, because this is the key which will attract the private health sector. And finally, try to base your financial model on diverse sources of financing rather than only one, because governments tend to face certain problems, especially again during these phases. I'm going to say it in Japanese. I will try, and actually, so Fukano Okano ni Soru no wa Dorayoko da. Thank you.
Thank you very much, Dr. Ihab. So now move on to listen to the evidence from the academia. JICA, together with the Senegalese university and the Senegalese government, have implemented the impact evaluation researches, both quantitatively and qualitatively. So first, I'd like to invite the Professor Nakamura of the Hitotsubashi University to share the result of his research. The floor is you.
Good morning. Thank you very much for the invitation. My name is Ryoto Nakamura. I am a researcher from research institution. So I'm not involved in policy making decision processes, but being invited as one of the stakeholders, maybe the research institutions being the stakeholders. So some challenges and opportunities of universal health coverage in Senegal has been addressed by 2 of our colleagues from Senegal. The Senegalese UHC system is started as a community-based health insurance and characterized as a bit modest insurance take-up rates currently. And I also want to highlight some we found using collaborating with the government of Senegal, some significant disparities in insurance take-up across the regions and departments. So huge variations in the insurance coverage and healthcare utilization and financial catastrophic expenditure. And I had an opportunity since 2017 to occasionally visit Senegal and travel around to observe households and also mutual health organizations who operationalize community-based health insurance. And as you see here in this picture, there are some good mutual health organizations with decent office and equipment and educated and trained staff members. And also there are some poorly operationalized mutual health organizations in just in the starting initial phase of the UHC system, UHC policies. And some mutual health organizations, they can keep records of their members and income and also healthcare payment by computers, while in other organizations did not have equipment, desks and furnitures, and therefore forced to manage some of the important documents on the floor. So there are huge variations, and we were interested about the relationship between the mutual health organizations' operational capacities and some of the universal health coverage important outcomes, because we observed the huge heterogeneity. So our hypothesis was the MHO's organizational capacity is associated with health insurance coverage, healthcare utilization, and risk financial protections. And also, we hypothesized that HMO's organizational capacity perhaps could be more important determinant of health insurance take-up compared with the individual and household characteristics, preferences and socioeconomic status, and other behavioral characteristics. So we, collaborating with JICA and the government of Senegal, we conducted surveys in 3 regions of Senegal to monitor the first MHO's mutual health organizations' capacities. We conduct the surveys, first survey in 2017 and second survey in 2020 to cover all the mutual health organizations in the 3 regions. And also in order to monitor insurance coverage and healthcare utilization and catastrophic expenditure, we conducted household surveys in 2019 and 2022. So we combined these 4 survey data to implement repeated cross-section analysis. So our key outcome variable of this analysis is household level and individual level insurance coverage, healthcare utilization, catastrophic expenditure, and our predictors variables. We had a supply side characteristics, which is MHO's operational capacity, and also individual and household characteristics. So based on the household survey results, we compared the outcomes between 2019 and 2022. So we saw, we have non-poor and poor in this figure. So poor, we refer to the households who are beneficiaries of the family benefit, who are supposed to be as a very ultra poor households who don't have to pay the health insurance premium by themselves. Their health insurance premiums are subsidized by the government. And non-poor, they are still informal sector, but they have to pay the health insurance premium, half of the health insurance premium by themselves. So between poor and non-poor, there are distinct incentives in insurance take-up. So we saw some significant increase in the enrollment among the poor from 17 to 38.5. But for the other statistics shows some modest, only modest increases, but still favoring universal health coverage achievement. But I want to note that some differences are modest. So we investigated in the regression analysis what is the determinants of insurance coverage at the individual level. So in the upper half of the variables are the individual level characteristics, while in the bottom half are the mutual health organizations characteristics. And we actually found that the individual socioeconomic status are the most important determinants of health insurance coverage, while the MHO's characteristics, they are statistically significantly correlated. For example, the education levels and training received, but the size of the correlations is modest. And therefore, we concluded that maybe at the timing of the surveys, the individual characteristics are more important than the. So we also conducted the analysis using healthcare utilizations, and also we did the prevalence of catastrophic expenditures. We found some qualitatively similar results as the health insurance take-up. So my conclusions: so MHO's operations through better staffing and training education and the partnership with healthcare providers, this was associated with UHC outcomes, but the size of the association was still modest. And we found that the household characteristics appeared to be more important determinants than the MHO's characteristics. So the interpretation, we have two interpretations. So the first one is maybe addressing individual behavior change, which has been already being implemented by making the insurance take-up as a compulsory rather than voluntary, as emphasized by our Senegalese colleague. And also, through the field surveys, we encountered the health insurance organization staff members claiming that there have been some delays in the subsidy from the central government. So even though the operational capacity of the organizations improved, but they still suffer from the shortage of budget, and therefore preventing them from sending their members to health facilities and paying the healthcare cost. And thank you very much.
Okay, thank you very much, Professor Nakamura. So the next presentation is about the analysis, especially on the qualitatively analysis of the stakeholders in the Senegal health financing protection mechanism. And I'd like to invite Mr. Togawa. He's a JICA staff, but he is also the PhD candidate working for the studying on the Senegalese health insurance mechanism. So over to you.
Okay, thank you for the introduction. So, as introduced by the moderator, I have two hats. So, I'm the JICA officer, and on the other hand, I'm the PhD candidate at LSHDM. So, I can't say, unlike Professor Nakamura, I'm a pure academic, but I'm trying to be objective to capture the process of formulating a new policy in Senegal. And please also note that this is the preliminary analysis of the ongoing process. So, what I present here is not conclusive or definitive, but I hope this will be helpful, especially for Senegal and also the other countries as well. So as a health financing reform is the complex and political, and the importance of political economy analysis is getting higher and higher. This year, even WHO published the guidelines on how to conduct political economy analysis for health financing. So in Senegal, as our colleagues from Senegal has just presented, they are in the process of health financing reform, and especially they are formulating the new policy called PSDCMU. It is in English, the Strategic Development Plan of the Universal Health Insurance Coverage. This is one of the key policy actions of JICA's development policy lending as well, and we conducted the key informant interviews and collection of some related documents to understand the collaboration processes in this policy making process and try to elicit some practical recommendations. So this is the analytical framework of this study. We combined two frameworks. The one is called political economy framework. This allows us to exhaustively capture the key stakeholders in health financing reform. And another framework is called integrated framework for the collaborative governance. And this allows us to analyze how these stakeholders interact with each other in the process of collaboration from the three aspects. So this is a slide just to confuse you. This is actually funding flow, and I won't go into the detail, but this is the funding flow in financial protection schemes in Senegal. So I won't go into the detail, but one of the particularities is here in the center, we have the service providers. They have the substantive budget from the Ministry of Health, but outside the Ministry of Health, there's a universal health insurance agencies under the Ministry of Family and Solidarity, where our colleague CTFI is from. And it is very fragmented, a complicated system, as you can see. So there are many stakeholders related, involved in this system. And this is another slide to confuse you. And this is actually the key stakeholders who are involved in the policy formulation process. And again, here, the Ministry of Family and Solidarity and National Health Insurance Agency, they play the key role to coordinate among those stakeholders to formulate the new policy. And these are the ones I conducted interview with for this study. So let's see how these stakeholders interacted actually in the process of formulation. So the first dimensions of collaboration is called principled engagement. This is actually how the stakeholders are actually interacted based on what kind of rules. So good practice is there was a ministerial order which defined the procedures and the members of the committees to be in charge of the elaboration of this new policy. And thanks to this ministerial order, the National Health Insurance Agency was able to recruit the competent consultant to draft the new policy. And this consultant did fairly good work, and also the development partners provided some crucial technical inputs with the local expertise. On the other hand, there are some things to be improved. That in this ministerial order didn't really specify the individuals or detailed affiliations of the committee members. So there was some confusions who should be represented from each organizations. And also in the actual process of participations, the participants are quite limited to the representatives from the National Health Insurance Agency, and Ministry of Family and Solidarity, and development partners. And when I conducted interview with the other stakeholders, they told us they should have been involved more from the early stages. And one of the reasons why they weren't able to participate in the process was most of the meetings were conducted online, and the invitation didn't reach to the right person in the right time. So this, of course, this is not the only reason, but this could be one of the reasons of the less participation. And the second aspect of collaboration is called shared motivations. This is about interpersonal relationship among the stakeholders, such as trust and mutual understanding. So good practice was there was good understanding and strong commitment from those who were able to participate. And also there was some notes of information and minutes of meetings circulated among all the stakeholders. But again, the rooms to be improved. There are some distrust amongst the certain stakeholders, especially with the community mutual health organizations. As Professor Nakamura presented, there was some long-standing problem of the financial deficit, and as well as some political issues with them. And there was also some lack of understanding in the program, the roles of national health insurance agencies among the stakeholders. And some stakeholders told me there were some tensions or lack of coordination between the Ministry of Health and the National Health Insurance Agency, which is shown by the fact that the Ministry of Health, they just started starting to develop their own health financing strategies. So this could be the issues when in terms of implementation of this new program. And the third dimension of collaboration, this is called capacity for joint actions. So this is what kind of capacity the stakeholders jointly developed in the process of collaboration. So the good practice was there was a good draft of the new policy, and this is fairly good content based on the studies conducted by the local consultants. And also this process of formulating new policy strengthened the network and led to the continuous collaboration amongst the participants. But this process didn't really materialize the better understanding and good relationship amongst a wide range of participants, which is really necessary for the implementation of this policy. And another thing to be noted is there is some lack of discussion between the Ministry of Finance and in this process. So even though the policy itself is good, but there is no guarantee for the moment about the financial feasibility and sustainability of this policy. So conclusion and recommendations. So as I said, again, this policy itself aims for the equity, efficiency, and sustainability, but there's room for improvement on the interministerial coordination, and also the distrust and tensions amongst the stakeholders should be addressed. And last but not least, the key takeaways for the development partners like JICA. I still believe the potential of this development policy lending, even though certified prefers the sector loan, because this could really promote the dialogue among stakeholders in the country as well as the partners. But we partners tend to hasten the process as soon as to disperse the money and achieve the policy actions as soon as possible. So this could be really the problem and leads to the misunderstanding, miscommunication among the local stakeholders. So we should be really very careful about the local context and political aspects of this policy making. So thank you very much. 8 minutes were too short, so I will have the poster presentation of this on this Thursday. So if you are interested in the more detail, please come and join us. Thank you.
Okay, thank you very much. We are a little bit behind the schedule, but now we'd like to move on to the panel discussion. So the presenter, please move on to the other seat in front of you. Okay, so I have prepared several questions for each of the panelists, and I'd like to start with the certifier. So after listening the two presentations from the academia, qualitative and quantitative researches on Senegal's health insurance, I'd like to have the reaction or responses to the presenters, Professor Nakamura and Mr. Togawa. And also, I think you have some requests or suggestions for the researchers of the academia to support the health financing reform. So may I have your comment, please?
So in order to talk about health financing, I would like to thank Mr. Togawa and Professor Nakamura for the surveys. I've actually read it through, and we have to understand that since 2020, we have also did an external assessment of the UHC system, because indeed all those issues was done, and the study that we had is actually going in the same line as you have done. It is a real issue. When you do the assessment, there has been a problem of subsidy payment to the mutual companies. It was a late payment, and it means that those companies were saying that the system was not efficient enough because the payments were late. So we started to develop a community health insurance at the beginning. And in 2013, we had 614 such mutual companies. And then we wanted to shift into creating 46 of them for each department. And in order to have bigger companies that could take more risks, because in the assessment was really an issue. Is it going to be sustainable if those small companies were not sustainable and if they could not take into account the informal sector and the agricultural sector? So indeed, the survey was interesting. And as you said, Professor, the local authorities helped those organizations, those mutual organizations, to become more professionalized, more excellent. So I think that now we managed to have this kind of skill strengthening, and JICA really helped us. So all those people working in those mutual companies were supported by JICA, and this was really well done. Albeit JICA cannot, of course, find all the places for all those companies and buildings and so on. So it's important that the state also, or the local authorities, give their support. And the last reform, which is phase 3, and it made it very clear that the local authorities should take part in the financing also. Unfortunately, it wasn't always perfectly done, but the idea was to have a bigger mutual companies so that they can take their risk and they can really cover one department, and so that we can have really the community dynamics be here to have more a premium being collected by the beneficiaries and also supported that. So it is important that the money goes to the department mutual companies. Another issue is for those who are not paying premium. So the poor that you said, we are, for those vulnerable groups, it is important to find what we called family security scholarships, and this will be 100% covered by the state and will be paid to the mutual companies. But of course, we need to have those people that are going to pay premium, and the state will add 50% to finance the system. So right now, if you have the smart card for those people that have handicaps, for example, this is also taken by a state. It is important that the state take its responsibility and pays directly those mutual company. So the idea is that we have a subcontraction of the services to the mutual companies, and they will be in charge to identify the people that have to have that will be beneficiaries, that they will be enrolled and get their card, their registry card. And then through digitalization of the system with the CSU, it means that if somebody has to go to a hospital or go to a doctor, would be paid, the cost will be paid directly by the mutual. Now, seeing the presentation made by Mr. Togawa, I thought it was very interesting in order to find the financing mechanism with the new system, which shows that social protection is a priority in the Senegal 2050. We want to be fair, to have equity. And right now we're looking for sustainable funding mechanism, because when we had the assessment, the issue of sustainability was very important. It's not just giving assistance for medical services that would be free For example, when you have child that are below 5 years, or the people that are over 65, or when you go to have a C-section and so on, this is free. But this is, of course, costs a lot of money for the state. So even if you have development partner like the World Bank or JICA, we have to think about financing or funding model that would be sustainable on the long run. So right now, we put in place a technical committee in order to think with all the stakeholders. So this plan, the PSD, is almost validated. It will be soon validated, but this has to be with the new development strategy of Senegal, which I told you about, so Senegal 2050, because the Prime Minister said very clearly that we had to be consistent with all priorities. So for the social security funding, we are thinking about a universal autonomous fund, and this fund will be in charge of financing or funding the whole system. So, of course, UHC will be included, but all other things. So the state wants to have a large structure that will be in charge of allocating all the funding. So right now, there is a decree that is being drafted, and we should go within a framework that will be identifying where we can get some money or earmark some sectors, for example, for the telephone sector or for the petrol sector, the oil sector, sorry. So try to see where we can get some tax that could be earmarked to those funding. Thank you.
Thank you very much. So the next question is for the Dr. Wangia. So in Kenya, the JICA is also collaborated for such a health reform through the development policy lending. And from the health sector side, you may want to have something to say, your proper opinion on the DPL. But my question is, did the DPL promoted the dialogue between the Ministry of Health and the other many stakeholders for the health transformation? And also, did it lead to the increased financing, especially for the health sector during the DPL or even after the DPL? And I'd like to limit the question, your answer response in the 1 minute each person so that we can close our session by 10.
Okay, so thank you very much. The government of Japan, JICA, supported the government of Kenya through one of the DPL. Within the health sector, we had 3 main objectives, and one of the objectives was to strengthen health financing, improving quality of care, and strengthening the M&D structures. So in regards to how this supported the country, and indeed, it was in alignment with our key priorities. So some of the achievements we got were, one, we managed to do our clinical guidelines, because that was one of the areas in which we were to tick that box for us to get the support. In terms of clinical guidelines, we supported what we call the Kenya Quality Model for Health. That is what fell under the quality of care. There was also the area around digitization. That's when the digitization discussions began, and right now they have been escalated. Looking at the aspect of health technology assessment, because we acknowledge that it's through evidence that we can improve even our prioritization, and just looking around issues to do with public finance management, which what you call the MTEF, medium-term expenditure framework. So through the support of course from JICA, 2 counties, was the whole aspect of the MTEF was strengthened in 2 counties, but the same guidelines were used for the entire health sector. So I would say yes, this support actually came in handy to address the priorities within the health sector.
Thank you very much. So now I'd like to ask the 2 representatives for the Minister of Finance, because I think many of the participants today are from the health sector people, and you need to negotiate with the Minister of Finance. So we'd like to ask some secrets. What kind of action from the health sector side is something effective to increase allocation, budgetary allocation for the health sector? So first I'd like to ask the Sete Joe from the Senegal, followed by the Dr. Ihab.
It's difficult to convince the Ministry of Finance. Very often, the explanation is quite strict, and in the case of Senegal, the Ministry of Finance, the first negotiation is to set the initial allocations. So these are budget allocations that are going to be set in July, the 1st of July usually in Senegal. And then you have the final decisions that will go in September, October, November. So in order to convince the Minister of Finance to have more budget for their sector, what is important is, to my point of view, is to communicate on the results you had so far. This is very important. If you want the Minister of Finance makes more effort in your field, he needs to actually explain what are the results of each field at upper level. For example, in front of the Parliament, the Minister of Finance is often asked what are the performance or the results of infrastructure, of the health, of education. So if you have one field that gives the Minister of Finance evidence that he will be able to talk in front of the Parliament, then he will be more ready to give you more money. And I say that because I've been actually within this decision process from 2009 until 2016. I was only in charge of budget, and I've really gone through that process of decision making. And I know that the authorities usually look really at sectors or fields that have good results and that are actually communicating and talking about those results and give them to the ministry. This is extremely important if you want to get more budget on the next fiscal year. This is something that is very important. This is our secret. Thank you.
It's quite convincing to everyone, I think. So the Professor Ihab, and followed by the Nakamura-san, Togawa-san, and the last in Yoshi-san.
Thank you. So I can depend on what he explained. It's the same ministries of the staff of Ministries of Finance. So it's an easy to answer question to some extent. You can ask, but most probably Ministry of Finance wouldn't accept. So this is the key word and actually of it. But we have to take into consideration two key issues. The first one is the redefinition of healthcare benefits to some extent, which moved from disability adjusted life years to quality adjusted life years. The second issue is that we have to take into consideration as well the health expenditure or health investment, whatever you position it as an investment in health or expenditure in health, the health expenditure paradox. To some extent, whenever you spend more on health, this will result in extended life years. This will result in more healthcare services needed for the elderly. So this will result in more spending automatically you need. So to some extent, it's not just, you should not just focus on on trying to increase revenue mobilization, especially in these times of very high inflation and very difficult global economic conditions to some extent. So on the other hand, for the financial stability, you might try to focus on the other dimension, which is working with the costing efficiency to some extent, working with health economics and health technology assessment, trying to be more efficient with your resource utilization to some, and of course, depending, and this is for physicians, we in universal health insurance are depending more on researchers and clinic and physicians to some extent for efficient and effective utilization of clinical protocols and effective medical interventions. Yeah. Thank you.
Okay, thank you very much. So now Professor Nakamura, after listening to the several opinions. Yes.
So thank you very much. It's brilliant. Since this session is about fostering effective collaboration through multi-stakeholders, and if the research institution is a stakeholder, I want to note that I have been privileged. I have been privileged to be working with the government agencies in Senegal and other countries. Have been always struggled to provide timely scientific evidence to support policy decision making, and so the research institutions are not free labor force. We have vested interests. I have a faith in Senegalese health system and also other countries' health system, and I genuinely interested as a research in health policies. But on my practical side of my job is that I have to be accountable to the dean, so who are interested in research income stream and also high impact publications and maybe fostering early career researchers, which does not necessarily always meet the interests from the policymakers. And if the research institutions or researchers can be involved in the policy making process more engaging more heavily, maybe this sort of even the how to collaborate and how to make this collaboration possible and easier is a very important issue to be considered. Thank you.
Thank you, Mr. Togawa.
Thank you. Just one thing. So unfortunately or fortunately, the new policy, the PSDSMU, it's still at the draft stage. So I really do hope you, after you coming back to Senegal, you will engage more with the Ministry of Finance and other stakeholders to really examine the contents and finalize it to successful implementation. Thank you.
Okay, thank you. Yoshi-san.
Oh, okay, yeah, thank you very much. The time is already running out. So just quickly, let me summarize all the discussion points and all the presentation. My takeaway message are including 3 points. So one is a requirement to development partners like JICA. We have to take care of the country's PFM system. For example, through implementing a development policy lending, we should synchronize and align with the timing of the fund disbursement within the Ministry of Finance budget cycle at the country level, so that it helps the line ministry, like a Ministry of Health, to develop the budget plans at the annual level and also the midterm level. Well, the second point is, I think that everybody mentioned about digitization of the health system. That could help to identify a target population in an effective manner. And also, it will also contribute to translating the data and evidence into the policy and practices. And the last but not least, since this session theme is a collaboration with within the multi-stakeholders, So one of the required expectation to development partners like JICA is to create a momentum, a global momentum, like utilizing this occasion like HSR 2024 to share the knowledge and experiences at the country level so that we could accelerate the progress toward the UHC at the country and also the global level. Well, thank you very much.
Thank you very much, all the other panelists today. So unfortunately, we are running out of time to taking a question from the floor. But right after closing the session and taking a group photo, I think all the presenter is happy to welcome your question. So please approach them personally. So thank you very much for your kind participation for the session.